Thank you very much. Thank you very much to the organizing committee for inviting me to speak. So I'm going to talk to you today about the role of ultrasound in diagnosing neuromuscular diseases. I don't have any disclosures. So I think, some of you were at the workshop yesterday. And you would have heard or read that now, especially in neuromuscular diseases, we're not relying just on nerve conduction studies and electromyography, but there is this emerging, not just emerging actually, in a lot of places, we're actually also utilizing ultrasound of the nerve and muscle to support nerve conduction studies and EMG in diagnosing and also looking at the outcomes of patients with neuromuscular disorders. But it's very important to realize that ultrasound, it's complementary, so it supports. You wouldn't use ultrasound on its own when managing or diagnosing patients with neuromuscular diseases, because at the end of the day, ultrasound gives you the structure, but it doesn't tell you about the actual function of the nerve. Okay. So as I put here, neuromuscular ultrasound, it adds by giving you the structural images. So you can do that for the nerve and also the muscle to look at its morphology. So just very briefly, for those of you who are not familiar, I'm just going to give you a little bit of, just to familiarize. So degenerative changes in nerve, for instance, you might see that. So this is the nerve. So this is somebody that's a healthy control. And you see that when the nerve degenerates, it will become thinner. So you can see that looking at the actual size, it might be smaller. So that's looking at the cross-sectional area, and this looking at it longitudinally. And when it's inflamed, so this is a normal nerve looking again at the structure. And when it's inflamed, you get a lot of fluid coming through because of the inflammation. And you might see the nerve become bigger. So these are some of the changes that we can see in the ultrasound. And as for muscle, okay, so muscle tends to look very dark, it's very black when it's in a normal person. But when you have a primary muscle problem, you find that all of the muscle might start looking white because you get that fatty change. And when it's a nerve, a neurogenic problem, you might see that it's very speckled, so scattered, as opposed to the whole muscle looking white. Okay, so these are just to give you an idea, because I'll be showing lots of images so that you see what the baseline is and you can understand how we apply it when we are approaching diagnosis of patients with different types of neuromuscular diseases. Okay, so the clinical applications would be typically you can use it for entrapment neuropathies, for peripheral neuropathies, for motor neuron disease or ALS, and also in muscle disease. So I'm going to go through it step by step. So for entrapment neuropathies, the most common, of course, we know is median nerve entrapment or carpal tunnel syndrome. And sometimes, often you get patients that present to you and you don't get anything. You don't get any it's inexcitable. You can't get the SNAP, the sensory potentials. Sometimes if it's really wasted, you can't get the CMAPs. So the nerve is still there. It's just that it might not be excitable because we can only give a certain amount of electrical impulse. So what you see here is that if you were to do an ultrasound, you will see that at the wrist, this is what a median nerve would look like in a normal person. But when you have entrapment, it causes a lot of edema, so fluid within the nerve. And then what happens is that the nerve looks much larger. Okay? So just by doing that, and one of the things that we do, so you would actually look at it at the wrist, and you would look at it at the forearm, so typically about 10 centimeters. And the idea is that the nerve, technically, it should be pretty much the same size. It might be a little bit bigger more proximally and become smaller. It's like a tree trunk. As it splits, it might become smaller, but it shouldn't be bigger as you go further away from the center. But with carpal tunnel, for instance, or median nerve entrapment, you might find that it's much bigger at the wrist compared to the forearm. So having that ratio of more than 1.4, that is up to a sensitivity of about 100%. And sometimes just doing that can help you with the diagnosis in entrapment neuropathies. Similarly, with ulnar nerve entrapment across the elbow, again, you're looking again at the entrapment site and also comparing it to an area where it's not being trapped. And usually we would use the mid-humeral. And doing that ratio also very, quite sensitive and quite specific to make the diagnosis of ulnar nerve entrapment at the elbow. Okay, so these are the two things. And if you think about it, you can pretty much use the same concept for other areas as well. So these are the ones that have been done the most, but you can use the same for fibular neuropathy across the fibula. You can compare that to at the popliteal fossa just to see the difference in the size. Okay. So moving on to inflammatory neuropathies. So if you think about inflammatory neuropathies, so the two main groups that we're talking about is Guillain-Barré syndrome and its chronic version, which is chronic inflammatory demyelinating polyneuropathy. So what happens, you already know about nerve conduction studies. We look at slowing, but again, sometimes the patient comes to you and it's inexcitable because there's a lot of conduction block. You cannot get the sensory potentials. So when that happens, it doesn't mean the nerve is still there. So you want to see what are the other features. So one of the early changes that we see is actually if you were to do an ultrasound of the cervical roots, because if you think about Guillain-Barré syndrome, it's a polyneuropathy, the nerve, but also the nerve as it comes out from the spinal cord. So the part that we call the radicals. And those areas are very susceptible. It's quite easy to have attacks at those areas because it's very sensitive to having nerve, inflammatory insults. So when that happens, you'll find that the nerve is enlarged at the proximal, and this might be the earliest changes that you see. Okay? So if you look at it here, so what you see here is the cross-sectional area. So this is what it would look like. This is C6, the root. This is what it would look like in a normal person. You can see that it's very enlarged over here. Okay? Of course, all of this is in the context of the history, but also the nerve conduction studies as well. So we've also looked at doing it serially because you want to see whether there is any improvement if it's Guillain-Barré syndrome. So what we have found, for instance, like, at the first week, it may be very, very big to start with. And then as the patient gets better and the inflammation, which is a one-off inflammation, when that starts to settle down, the nerve also starts to become smaller as well. So you can also use it to try and see whether there's improvement in terms of the inflammation. And sometimes that can help in terms of whether you need to, to give the prognosis. How well is the patient going to do? We know that we don't give a second IVIG in GBS, but at least you can know and inform the patient, get rehab involved much quickly. So next is CIDP. So CIDP, it's a much longer period, okay? It's not a one-off episode of inflammation, autoimmune attack. So it comes and it goes and it comes and it goes. So it goes through demyelination, remyelination process, keeps demyelination and remyelination. So in the nerve conduction studies, you will see that it's very slow. Sometimes the patient gets better. The nerve conduction studies might not still show any improvement because even when you remyelinate, the nerve is still very slow. So if you look at the actual nerve on ultrasound, you will see that it's usually very large, much larger than you would see in GBS, for instance. And the ultrasound tends to be much bigger. The cross-sectional area tends to be much bigger the longer the person has had CIDP, because they go through this remyelination, demyelination, remyelination. So that process is being picked up, and you can see it on ultrasound. And if they're much weaker, and if they have, so there's this disability score that is being used internationally. So if they have a worse disability, and if they have a very progressive disease, the ultrasound tends to be abnormal, and you might find that the nerve looks much bigger. And the velocities are usually lower in the segments where the nerve is much bigger as well. So there is that correlation with nerve conduction studies as well. And the segments that have the myelin damage, you will see that these are much bigger than where there is axonal involvement. So one of the things that you find that's quite characteristic with CIDP is that where it is most enlarged is not in the area where you have entrapment, is actually in between. So if you look at this study that was done, it's a Korean study, so you'll find that the cross-sectional area is actually much worse. So for instance, this is C, this is D. So E is actually where the sulcus is, and it's actually not that big over there. So when you see this non-entrapment, and as you go more proximal, the nerve is much, much bigger, that is quite typical of CIDP, okay? And similarly also in the lower limbs as well. And other things that you can do, when you have the ultrasound machine, you can very quickly turn on the Doppler to look at the vascular supply. And of course, because if it's inflammation, you might see more vessels in patients with CIDP with Doppler compared to somebody that doesn't have it. And as I said before, the longer the duration, the bigger the nerves. And what you see is that, I said earlier that proximal tends to be bigger than distal. That is what you see in the acute phase. But when the person has had it for a long time, it's actually bigger both sides. So you don't see that difference. Okay, so there's a few, I've only got about 7 minutes, so I'm going through this quite quickly. So inherited neuropathy, this is really, I find that ultrasound is very useful for this, because a lot of the time patients with Charcot-Marie-Tooth disease, by the time they come to us, the muscles are all quite wasted, which means you cannot find any CMAPs. But the nerve is still there, so you don't know what type of CMT they have. Because the CMT, you look at the velocity, right? But if you don't have CMAP, you don't have velocities. So what we have found is that with CMT1A, the nerves are very, very big. So, and it's big throughout, because with inherited neuropathy, it doesn't follow the inflammatory where proximal is bigger than distal. And one of the things that you will see, and this is a group work done by the Japanese group, CMT1A is very, very big, the nerve ultrasound, and much more so than the other types of inherited neuropathy, like, so MPZ is CMT1B, and then you've got connexin, which is CMTX, so much, much bigger than that. So I've had patients where they come to you as an adult, you look at the nerves, it's very big, you have a family history of autosomal dominant. Those are patients that's going to turn out to be CMT1A, even without doing you can do the genetics, but most likely that's going to be the diagnosis. And we've also done a study looking at the muscle. So this is looking at the muscle of the tibialis anterior, because that's wasted. And these you will see that the CMT1A compared to 1X and 2A, so this is axonal form of CMT. So you can actually use this to map to see whether or not how much the progression is, and to see whether it actually correlates. So in future, if you have treatment, at the moment there isn't great treatment for CMT, but if you have treatment, this could be something that can be used as a biomarker. And again, you can also look at differentiating. So other things that you can differentiate is that you'll see an entrapment pattern, for instance, in HNPP, in the amyloid form of familial neuropathy, and also in Fabry's disease. So very quickly, there hasn't been a lot of work on this, but we did actually look at diabetes, and we found that looking at the sural nerve and the tibial nerve, it allowed us to actually compare, to look at the more severe your diabetes is, your sural nerve is actually much bigger. And that's, you might think it's a little bit unusual because you expect it to be degenerated, but actually there's a lot of edema that comes along with diabetic neuropathy in particular. So one of probably the most important use, especially, in our practice, is actually using it in ALS. So you can look at nerve ultrasound. This is probably, not as useful as muscle ultrasound, which I'll go through. But one of the things that we do see in ALS, because it's a degenerative process, you see that rather than have it bigger here compared to here, it's the other way around. You find that because you have more motor fibers proximally, you find that actually it starts to become thinner more proximally compared to more distally. So that's quite helpful, because one of the things you want to do is also differentiate it from some mimics, like MMN, for instance. And MMN, you should see that the nerves are much bigger because it's an inflammatory neuropathy. And also we looking at it as a prognostic marker, and we found that using the nerve size was also very helpful, together with looking at the fasciculation count. So muscle ultrasound, for those of you who may or may not be aware, so we've got a new criteria now called the Gold Coast criteria. So that has simplified things, moving away from the LS Coriel and Awaji criteria. So now, rather than relying on EMG, the idea is to try and diagnose patients with MND or ALS much quicker. So the hallmark is that you have progressive weakness that is painless, and there is upper and low motor neuron involvement. And whilst the previous criteria did not talk about ultrasound, the Gold Coast criteria does include muscle ultrasound as supporting the diagnosis, especially when you see fasciculation, which represents low motor neuron findings. So usually the protocol would be to do it, and you can see here, this is a patient with biceps at rest. You can see that you can see twitches there, and this is FDI. Yeah, you're convinced? I hope. So you can see the twitching. So this is spontaneous twitchings, and that's what fasciculation looks like when you do muscle ultrasound, okay? So 30 seconds, and in the context, if you see this and you have somebody also that has a brisk reflexes and they present with a history that's suggestive of progressive weakness, this is very consistent with ALS, okay? You might find that if you do EMG, it's just a needle, and if you don't hit the spot of the muscle that is denervated, you might not find anything. Whereas with ultrasound, you can see a bigger area to help. Okay, let me just move. So these are some of the muscles. You can have a look at this paper, but basically the ones that I've highlighted, there is a score that if you have more than 2 scores in the 9 selected muscles, it's got 92% sensitivity and 100% specificity in diagnosing ALS. So other things that you can look at is the muscle architecture. So this is one of my patients. This is at 10 months of the disease onset. And you can see here, you can still see some black. So that is reasonably healthy muscle. But 10 months later, this is already denervated much, much more. You can tell that, right? So you can also look, rather than just, doing the MRC grading is just very, very crude. Doing the ultrasound, you can actually be able to compare more objectively, because there are objective measures of doing this. A very important evaluation is looking at the respiratory muscles. So we do vital capacity, but the patient can have muscle weakness and it takes a lot of effort. So you can't really detect that very well. So one of the things that we do is look at the diaphragm as well, okay? And this is what you have to get used to it. So this is your diaphragm here, and it's over here for the patient with MND. So if I play here, taking a deep breath in, you can see the diaphragm enlarging here, okay? But in the patient with motor neuron disease, hardly moving, just this bit here. Don't know whether you can appreciate that. So just doing that, you can detect at an early stage whether there is actually respiratory involvement. Okay. Muscle disorders, very quickly. This one is just about recognizing patterns, and you know that with muscle disease, it tends to be more proximal compared to more distal. So rectus femoris might be more involved compared to tibialis anterior, unless if you have the more distal forms of myopathy. But like I said, it's very homogeneous. So it looks, the whole muscle tends to be involved. Other things that you can look at, for instance, inclusion body myositis, very, very focal myositis. So this is normal. You see FDP here, and here you see how just the FDP is involved and the others are spared. So this is very characteristic of inclusion body myositis. And finally, for kids, you can look at specific types of myopathy where with this one, you have other muscles involved, but the rectus femoris is spared, for instance. And for the collagen 6 disorder, you get the central cloud pattern. So these are things that if you can identify, it helps to support the diagnosis so you can target your genetics much better. So in summary, at the end of the day, neuromuscular ultrasound must complement NCS EMG, okay? You still need the NCS EMG. It has good sensitivities if you want to differentiate between neurogenic and myopathic process. It's very, very useful when you cannot excite the nerves. And also the dynamic studies are becoming much, much more important. The most important thing is that whatever you do, standardize your protocol because different machines can look different. So you need to make sure that you keep things standardized. And with that, I end my talk. And for those of you who haven't registered, please come to Jakarta for ICCN next month. Thank you very much.